Welcome to the MedMasters webinar. We've been having a lot of these, about one a week, because we've had extreme interest in the topics. We love to share good education. This sparks interest and lets us know where else we might need to go with our education and our products. And we just love seeing you guys and talking to you guys. So we appreciate you being here every week, but obviously if you can't make it, these are always recorded. You can find those on our MedMasters, Master the Art of Healing YouTube channel. There is another MedMasters, so make sure it's the little blue and gray book that's really cute. And there's just a few of them there now, but we've gotten really good results and feedback and views on them. And there's information there in terms of contacting our guests, getting access to resources, products, services that we talk about within the webinar. So again, welcome live with us here. This is MedMasters, Master the Art of Healing. I'm Kim Look. We've also got Vicki Linnemith who's here, and she's a co-partner with me, and she does a lot of the back end and the scheduling services. You may see Jason De Leon. He's also part of our team and a co-partner. And he does a lot of the on-site train, especially with our EBU. So I did get a little bit of feedback last time that I did not introduce MedMasters well enough for those of you that are new. You may know us from previous organizations and working with O3UV and ozone and UBI equipment. SOPMed is no longer, and now we are MedMasters, but we are a different entity with different focus, different trainings. We've evolved in so many ways. And so we have different offerings, but we are a training company. We want to be here to provide good medical knowledge, as well as helping you implement full business development. So let's say you want to learn about peptides. We want to help you not only learn it, how to integrate it in terms of prescribing it, dosing it, stacking it, whatever the terminology needs to be, and then getting your staff all inundated, getting it in your EMR, your SOPs, all those things, well into the patient side of things with patient education, expectations, marketing, and even the big picture, which it might be wealth management, might be leadership, marketing, social media stuff. So we are not just a medical training company. We really hope to take it full circle for any one topic that you're here to learn about. So that's a little bit about MedMasters. We really focus on helping practitioners empower their patients with good services. Oftentimes that is in regenerative, integrative, optimization, functional medicine spaces, and usually our cash services. And so that does take a lot of work to fully get it to a place where everybody thrives, everybody gets to benefit financially and physically from this super cool medicine. And that is why Doug is here. Doug Rainey was a guest a couple weeks ago, talking so much about peptides and sourcing and legal components to peptides, because you may have heard the laws really, Doug always says they didn't change. We just became a lot more aware of certain aspects of the laws about last September, October. And so I'm seeing in clinical practice this difficulty of understanding what those laws really are. So if you go to our YouTube, you'll see that recording where we talked about the legal side and the sourcing side for peptides really heavily a couple of weeks ago. Today, though, we want to talk more about human cellular tissue products. I think that is right now our universal accepted term. Doug, correct me if I'm wrong, but I feel like we can say exosomes, we can say stem cells, especially in regards to what studies are there that are available in terms of what is an exosome, how does it work, what do we know about it, and then, how have we studied it? So those are real terms. We have stem cells and exosomes in our body. We're not like can't ever say those words, right?
Correct. Yeah, this is one of the more frustrating things that we've had to address over the years. I won't go back to that last webinar too much, but you and I think we scheduled an hour and we were about an hour 50 when all was said and done. So that shows everybody how much information there is on the topic. Yeah, we got a little bit off track at the end talking protocols, and we probably strayed a little bit from the title of that webinar, but Lots of information on regulatory compliance, etc. The question that you posed it is an interesting one because you've probably heard from various vendors out there that there are certain words you can and can't use, and there are certain things you can put in writing versus what you can say. All of those things are true. With that said, I personally don't see there being any reason why you can't say the word stem cell, exosome, etc. These are, like you said, these are real things. These are real molecules. These are actual cells. There's nothing illegal about them. It's once you cross that regulatory line of what are they doing, what are they being used for, what is the intention, application, indication, marketing, claims, all of those words come to mind. So I think the idea is we kind of we went pretty deep into it before, we'll gloss over it now. The idea is pick one route, one of two routes. One being either you're going to talk about what they are, how they work, where they come from, all the fun sciencey stuff, and stop short of making any call to action. Come into my office and I'll treat these conditions with these products. The other option is talk about the types of patients you want. What is it that you're good at treating? What types of clientele do you want walking through the office? And then once they get through that door, that's when you speak to them more intimately about what you have, how you may treat it. This is where you get into consults and consent form, which I do think this is kind of a difficult topic to broach, but it's a very good sales opportunity. Having a really good consent form actually gives you the opportunity to openly explain what your products are, what they're for. You don't want to mislead people when they're getting ready to, I don't want to say sign their life away, but commit to working with you. I think we talked a little bit last time. I had spine surgery about 1.5 years ago, and the consent form that I signed was like, basically, chances are this won't work. You may not wake up. You could wake up paralyzed, right? They're like all these awful things. And meanwhile, I'm getting asked some pretty straight questions about suggested consent language as though it's difficult when you talk about doing something IV or intramuscular or what have you. And it always makes me laugh. And I think to myself, man, these people have been fortunate enough to never have had surgery or do not have a surgical background, because the consent forms you sign in the rest of medicine are so much worse. So anyway, I digress. I do think that those words have been given a kind of a bad name, and it's because people don't fully understand what they're allowed to do with them versus what they can say about them.
So tell us a little bit how you know all this. I mean, you've already made it clear you're super knowledgeable, and we'll dive deeper into this, but how did you get involved in this in terms of understanding the different types of stem cells all the way into manufacturing, or not just stem cells, but these products, right? And then manufacturing, and then even the legal side of it.
Legal side, I'll start with that. Legal side was just sink or swim. I've genuinely felt like if you don't properly understand that as a consultant, you really can't help your partners, your business partners. And I consider all of our clientele, all of our physicians to be our partners. You can't properly help them be guided down a path that's safe, that is going to have some longevity behind it. I mean, you mentioned earlier about MedMasters' intentions not just being this one focal point the way that it was with SOTMed, but you have this broadband point of access now where you can help not just with protocols and implementation, but full-scale business. And I've certainly felt that way too. I don't think it's appropriate to just kind of hand these things off to someone. They need to understand every aspect of how to utilize them, just like they may have if they had gone down the surgical route. And that's where I started. So I started with Johnson & Johnson, DePuy Sports Med forever ago. I've had a long stint in chronic wound care. So again, allogeneic sources there. Autologous sources actually with J&J. So bone marrow, PRP, which we still do today. Even adipose, we've had a handful of different types of products, whether it's stromal vascular fraction, adenizer, many different versions of how you can use adipose and how you can access the cellular content there. Also, this doesn't even get into the extracellular matrix components. So all of these scaffolding components you may have heard about. So I know we don't want to get too into the weeds on all of those different things today, but I would say I've learned through a lot of experience and honestly just working with a lot of folks who are way smarter than me. I think one of my few superpowers is being able to kind of compartmentalize all of these different types of information and then figure out how to synergize them. In what instances do they make the most sense? In what verticals of medicine are they best applied? And even a lot of these same products are being used in all sorts of similar applications. So as an example, you could look at orthopedics. There's a ton of literature on bone marrow, on PRP, on adipose. There are different versions of adipose that are being used. Then you move into allogeneic, and you've got tremendous amounts of information on even cord blood, which most of us don't use anymore. You know, I feel cord blood for the most part is kind of an antiquated technology. It certainly has its proper uses still today. It's the only FDA approved allogeneic source. So it's actually approved for revascularization of the immune system after leukemia. And I believe it's specifically pediatric leukemia. So again, very, very specific. But right, so you can imagine it works for that, but it also works in joints. How interesting, right? Wonder how that's possible. So the signaling components are very similar. We've just gotten to the point now where we can access, for example, either isolated mesenchymal stem cells or at least tissue-derived birth tissue derived, which in my opinion is the optimal source. Doesn't mean that there aren't other ideal applications for these other autologous scenarios as well. But if you had to categorize them, I've got my opinion just like everybody else does.
I wanted to throw a couple of those comments in there, is that Doug and I truly come from this space of giving information. Like, we just want providers to feel empowered and to have a place, a resource, a starting point to learn more. That is what this webinar is designed to do. That's what MedMasters designs to do, and I know Doug's businesses as well. That said, after you spend a lot of time in one space, a lot of time in clinical practice, you end up having opinions and you end up having products or companies that you tend to side with or endorse or whatever. So there is that caveat and disclaimer here that Doug has his businesses, we have ours at MedMasters and those that we refer to. But we do feel like we've chosen those based on good information. We are happy to share them if you want them, if you need them, but truly this is designed to just give you the opportunity to have the conversation too. So that's the second thing here. Make sure to use the chat. If you came to this conversation already having some questions in mind, maybe you've heard other lectures, maybe you have salespeople knocking at your door, maybe you have patients who are asking questions, like, please put them here in the chat. We would love to address those as we go or even at the end. We would like it to be a conversation of sorts. The other thing before we move on, Doug, is I just wanted to let everybody know, I'm going to share my screen just really quick. I'm going to, this isn't set up to share the right setup here. Whoa. Okay, I've got a lot of slideshows open. I wanted to show this one just so everybody could see it. So we are having a much bigger opportunity to really get into so many aspects of peptides and human cellular tissue products. This is our free conversation. But we do have a 2-day training, as always, again, to provide as much information as possible on June 7th and 8th. It is live, but it's virtual. So you can attend from anywhere. You can have teammates, employees, staff members, affiliates, associate docs, whatever you need to attend. We're offering an early bird special from now to the end of the month. So it's normally going to be $750. Here's the code for $700. So we're not expected, create expectations for anybody participating. This is not going to be everything you need to know about this topic. But you'll see here some of the speakers. I'm so excited about this lineup. Doug Rainey is going to be back. Lexi, you guys know she's going to be addressing some gut things with human cellular tissue products and peptides. Suzanne Fury, doctor, some might know her as Suzanne Turner. She is speaking at ACAM in the next little bit. She's spoken many times on peptides. She's definitely an expert. She has a book that just came out, some products that I'm super excited to talk about. So she'll be there. Jeff Cohen, he is a law firm. He's an attorney. So again, everything comprehensive. You want to know what you need to look out for in terms of your scope of practice, your boards, you know, what these, he is an integrative healthcare attorney. We got Leonard from New BioAge, and his whole business is about peptides. Brett Sandala is somebody with marketing. He's got I worked with him in Avi Herskowitz's office 6-7 years ago. He was doing social media marketing for stem cell products or human cellular tissue products. So this is just part of the lineup. I just want to put this out there. There is an early bird special. In fact, I'll say today that if you sign up today, we'll give it to you for even 20 bucks off that, like $680. And if you're a member, you already get 10 or 20% off of this class. So it also will help us if you put your questions and comments in there. It'll help us direct this class too, to make sure that we can give you the information that you're seeking and maybe set some of the records straight on some of the confusion out there. So I'm gonna stop sharing my screen, or did I already? I don't think so. Here we go, stop share. All right, so Doug, like, I am still hearing so much conversation around what's better. Like, what's the right product? Is it an exosome product? Is it a fat product? Is it a bone product? Is it a placental product? Like, how does a practitioner sift through the whole circus of, forgive me because we're both kind of in this boat, but the sales person aspect? I just had a conversation with a company and they're like, because we're the best, we're the best, we're the best. And I'm like, can you provide data? Can you tell me where it's derived from? Can you tell me about your manufacturing? Well, I just want you to know we're the best. And it's like, okay, so how does a practice?
We're the best. We're the best.
Yeah.
Yeah, like I
Yeah.
know it's super frustrating. Let me start by I feel like I spoke somewhat negatively about cord blood, and I didn't mean to do that. We don't use it, and very few people still do, but there are scenarios where it is absolutely the best choice. I'll give a personal family example. My aunt was diagnosed with aplastic anemia. So when you have a scenario, I can't go into too much of the disease state explanation here, but something to the extent of your bone marrow is not producing proper megakaryocytes, which are not giving off enough red blood cells. And so you have decreased oxygen transport, hemoglobin's not working. Again, I'm screwing this up royally, I have no doubt, right? But it's something to that extent. Like in that scenario, if a bone marrow transfusion is not available, then cord blood would be an excellent choice. It has a lot of hematopoietic stem cells, HSCs, blood-based, transporting oxygen, et cetera, for someone whose organs are suffocating. Just one of many examples, right? You could imagine other blood-based conditions, cord blood might make more sense. So I'm not saying it is not still a good weapon in the arsenal. Sadly, it's rather difficult to obtain a good source these days. But point being is, for anyone that's like, because we're the best, they're not addressing any individual, either patient interest, concerns, or whatever the physician's specialty is. Again, I'll just, for sake of ease, let's talk about orthopedic sports medicine type applications first. I mean, these folks have used just about everything over the course of, however many decades we've been studying this stuff. And we've seen really great results with just about everything. Even PRP, which arguably is the most variable of all of them, right? You've got all sorts of different processing systems, all sorts of different techniques where people make it themselves, all of these different companies trying to teach you how to use a BSC hood in your office and a cell counter and multiple centrifuges where you're exposing blood particles to all sorts of environmental factors. There's a million different variables that go into this stuff, not to mention your own comorbidities. So somehow we've been able to get really, I wouldn't say reliable or repeatable, but we've gotten really great data out of PRP. There's a physician that we work with who always says it is the Indian, not the arrow. And I think this is such a great term that, look, if you understand how these things really work, and almost more importantly, you really understand the underlying causality of either the condition or the disease state that you're treating, you can really leverage these things to be super impactful. Now, of course, this was a total cop out on your question. I understand.
I was just gonna say, what I hear you saying is.
Right. So yeah, pick whatever you want. I think understanding that we could have multiple webinars in a row on all of the different variables that come into play when you're making your decision. If you're asking me to kind of summarize why I think there's a certain vertical that probably is most repeatable, the reason I pick birth tissue is a handful of reasons. First and foremost, birth tissue, the birth underline, will start there. It's super young. So you have very almost non-existent rejection factors, especially the fact that it's tissue and not blood. So cord blood, even though it is birth, can also have rejection factors because it is red blood cell based. So you have almost no red blood cell content in the birth tissue products, of course, assuming they're being processed correctly. So the lack of rejection, the lack of potential for graft versus host, those types of things from a safety profile, it's really difficult to beat. On top of that, it does not require processing. So I should be more specific. It does not require in-office processing. So it doesn't require anyone to be excessively trained. You're not worrying about the same variables that you would with, again, things like PRP, bone marrow, even adipose, right? They're kind of, in a way, you're beholden to what the system is that you have on hand and how well trained is your technician. And then sadly, some other potential variables that can come into play as well. So it is a much more repeatable and predictable product. You also are looking at a growth factor profile, which inherently is the mechanism of action of just about all of these products. Basically that exosomal component coming out of the cell is the actual communication factor, even from allogeneic to autologous. And so that profile is defined by the parent cell coming from a birth tissue. A is younger, therefore the profile should be more specific. And then B, being that it's a tissue source, depending on what you're using it for. This is where we'll talk a little bit more about that whole cord blood potential, like very, very small fraction of the population would have a more specific need for that product. It's just rare. Most of the things that we're treating in clinic these days, it's just not as specific to the cord blood profile, which is why birth tissue 95, let's say 95% of the time is going to be, I would just suggest to look into all of those different variables that at least you're eliminating when it comes to your scientific method. Now we're not having to worry about this. And we know that our growth factor profile is significantly higher. Our, chance of having a mutated cell is much lower because it's early stage, right? You start to look at all of those other potentials of things that could affect the outcome. You just get a much more repeatable product and predictable product with a birth tissue allograft.
So does that mean, because you mentioned earlier that depending on what you're trying to treat or understanding that diagnosis or disease, maybe the patient's stage or goals with that, and then what each product does, are you saying that with your choice or what you just mentioned in these tissue products, younger tissue products, that they're pretty universal to the condition or the symptom or the diagnosis because of the factors you just mentioned?
Exactly. Let me give, and I'll just try to play devil's advocate to give you a scenario where you could certainly make an argument otherwise. So adipose, for example, ADSCs have a great history of turning into chondrocytes. Now we've been able to see in the lab, you can easily flip a birth tissue MSC into all sorts of different tissue types and then back. So you can literally turn them back and forth. It's amazing. But in terms of what naturally happens in the body, responding to different chemotactic signals in the body, ADSCs have a pretty high propensity to turn into chondrocytes, pre-cartilage cells. Now, is it realistic to tell everybody that comes into your clinic with osteoarthritis that our end goal is to regenerate cartilage? That's a tough ask. I don't care what the product is. I really don't. There are so many variables that go into whether or not you're going to actually be able to see cartilage regeneration 6, 12, 18 months down the road, on an x-ray or what have you. It's very, very difficult to do. So I'm not necessarily suggesting that is how you consult your patients anyway. So there are other symptoms that we're treating, right? We'll kind of go back to that whole pick a path for advertising in your clinic. Either you talk about what it is and where it came from and what it does, or you talk about symptomatic marketing. Hey, do you have pain from osteoarthritis? Do you want to get back to doing the things you love? Do you want to, the father-daughter dance, your daughter's getting married, you want to dance at her wedding? Come into our clinic. Give us a year and we'll fix that. But we're not going to tell you how until you come in. And then you go through, okay, you're, in your late 30s, early 40s, autologous might be a good option for you. But you're later on down the road, you've got these comorbid factors, et cetera, et cetera. Maybe we talk about doing something a little bit different, more along the allogeneic route. So again, I just say that to give all of these different modalities their own credit. It's rare that you're going to have a condition that can't be helped by just about any of these products, but picking the right weapon in the arsenal is the responsible thing to do. And in order to do that, you do have to have at least a baseline understanding of what types of cells are coming from each of these products, how viable are they, how old are they, like what's the residual growth factor profile in a birth tissue cell versus a 45 to 50-year-old autologous bone marrow cell, right? And at what stage does it make sense, especially when we're talking about oftentimes repeat treatments? To tell people that you're just coming in for a one shot and done oftentimes is not realistic. So in what scenario do these things balance out where, if you're going to do an autologous procedure that allows you to bank some cells and come back, maybe it's a better bang for your buck. But there are very few clinics doing that correctly. So it's not.
I was going to ask, is there anybody here who's doing their own? Is there
It's
anybody?
rare. I know of a handful. It's rare. I'll credit where it's due. Cell Surgical Network is talking about things like this. And they're
Still
actually
around,
talking
huh?
about, yeah, so Sean Burman and those guys won a sidebar landmark case in California almost 2 years ago now, but against the FDA. We don't have to go into that too much, but for those of you that don't know, definitely look up Mark Burman started this with Cell Surgical. His son Shan finalized it, but long story short is they basically won a case against the FDA demonstrating that their product, if you're creating stromal vascular fraction in the office, collagenase does not count as a drug. It basically doesn't turn the product into a drug. So they still have access to be what you would call a 361 as long as it's same day surgery. And now they're also talking about doing all sorts of, I guess you call it culturing, cell expansion as well. So anyway, we know all of these things can be done. You're now being asked to weigh what's the value of my access to this technology compared to what is my assumed risk of having using / advertising said technology. And I think as more of us get educated about what those risks are, we realize that they're not quite as bad as we thought they were.
It's fascinating. I have this sense, and this is totally like, I was going to say, I feel, like this has turned into a big market. Maybe it has been there for a long time, but it can be an expensive therapy, especially if you're tapping the iliac crest and you're harvesting and we know providers charging $100,000 for those procedures. That's probably the high end, but they're doing it. I've got a couple, franchises on the horizon where they want these human cellular tissue products to be part of their network. But that also means that I feel like maybe you can clarify this, that there's been watered down products, a desire to create less expensive products, and maybe that sometimes gets in the way of the difference between like a younger tissue product and an adipose product. Is that aligned at all?
It is. I certainly don't want to use any vendors' names here, but I'm familiar with just about all of them. And I have noticed two things. One is the interest in accessing, let's just say, the topical aesthetic market, has sadly produced a lot, in my opinion, again, it's produced a lot of products that are being advertised, excuse me, and advocated for in very similar ways to much more expensive, much more effective either live cell products or isolated products that are much more effective, that have completely different application profiles. And part of the reason for that actually has a lot to do, in my opinion, with the fact that the FDA has kind of provided this loophole pathway, if you will, being labeled as a topical cosmetic. That's closing this summer, I believe in July. All of these cosmetic companies will finally be required to register. And
Cosmetics of all types, by the way, not just these human cellular tissue products, but it does, if it's a peptide topical, if it's an ozone topical, if it's vitamin C topical, yes, all topicals are now
Yep.
being monitored.
And interesting sidebar to that, the FDA consulting group that I've been working with that explained this to me, one of them is ex-CBER, Center for Biologics Evaluation and Research within FDA. The other one's a current FDA lawyer. And they explained that, of course, the FDA found a way to kind of screw this up a little bit. And these registrations will be listed as drug registrations, just to make it even more confusing for everybody else. So even an HCTP-based cosmetic will be listed as a drug. It's just, you can't, I don't even know how to explain that. I don't know what their options were and why they decided to bloop, but anyway.
You guys, it's the reason why we're here even. I was with a business coach this morning, very, very successful business entrepreneur in all different sects. And, you know, we were talking about strategy, we were talking about businesses. His clientele is entrepreneurs of all kind. That includes you guys. And it's just this question of how do you strategize in business? How do you, what do you look at in terms of what needs to change, et cetera? And he said to me, he said, Kim, it's no longer like build a business and it will operate for a year or 10 years. Like that has never been further from the truth. Now he's like, I operate in quarters, because every single quarter we have to reevaluate the economy, the purchasing system, the laws is where I'm going with this, right? FDA is changing all the time, all the time. I also have consultants and attorneys like Jeff Cohen on call all the time. And it's like, you have to be, this is a full-time job to pay attention to the way that they are managing, imposing, regulating. It's what we do, it's what we deal with. And you can't learn about it today and then think you know what's going on in 6 months. It will change. And then there's the trends of, purchasing and sales and all this other stuff that shift with it. So it's another reason to stay current on these conversations and never think that, oh, I heard that or I knew that, because it's changing all the time. And if we're going to survive in business, we've got to kind of learn. I don't think be experts like Doug in every single aspect, but definitely be paying attention to these conversations on a regular basis, because it's always changing. Here we're talking about topical uses as drugs, and it's going to change everything. It's going to change the way Amazon sells, every half of what they do, right? So, and this is why we talked about pharmacy versus lab the last time you were on, because these pharmacy law changes, and there's also so many different interpretations of it, both on, your side of it and the practitioner side of it. And, Leonard, from New BioAge, that is a pharmacy. And he talks a lot about that it's interpretation of the law, and it's not so black and white all the time. It's not so concrete and then doesn't change for a period of time or a long period of time. So again, just coming back to, keeping these conversations going, being able to look at the, cash flow analysis of your business, but also, how are these laws going to impact us, and maybe even trying to, I don't know, project where this might be going from people who are a little bit deeper in the system than we are as providers. But yeah, it's an ever-changing world. It's hard to stay on top of it.
I don't want to blow everyone's brain here with this homologous use and minimal manipulation, but since you're talking so much about having an attorney and having a consultant, I'll try to keep this really concise, because we could, again, spend an entire day and still have no idea what we're talking about with this. I've been recently kind of re-explained. Let's start with the minimal manipulation criteria. So when you're defining what is an HCTP versus what is a drug, 361 compliant HCTP versus 351 drug. The FDA has essentially, in so many ways, defined that the umbilical cord, accessing anything within the umbilical cord, constitutes more than minimal manipulation once you process it, because the cord itself looks like a pen, right? It's in this shape. Let's just say you kind of strung it out, right? So imagine similarly a femur. Femur would be kind of in that same shape. Now, they're saying as soon as you go through your dissection process and you remove the veins, now you're determining the different layers of tissue that you want to use for whatever particular product. That in and of itself, they're saying is more than minimal manipulation. And for all intents and purposes, any birth tissue product is no longer minimally manipulated. Now, at the same time, let me remind you, there are 361 regulatory opinion letters from the FDA that I have in my possession from other wound care companies that, again, I've represented for over a decade now, where the FDA has said, yes, that is a dehydrated amnion chorion, so combination product, two different tissue types. Again, dehydrated, not normal, dehydrated. So more than manipulated, combo product. It's just being used topically as a barrier. So you can't say it's a wound graft because that would insinuate that it's healing a wound. But yet that level of manipulation, they've actually signed off on and said, no, that's not more than minimal manipulation, but you certainly can't access anything else within that umbilical cord. And right, it's the hypocrisy abounds. Similarly, I brought up the femur bone because I've had a stint in trauma where you have all sorts of, let's just say as an example, cortical and cancellous chips that you would use inside a spine cage, maybe in combination with putty, sometimes in combination with even marrow. You know, there's all sorts of different ways you can do that. Clearly, more than minimal manipulation. You literally ground it up and changed the structure of it, and it's no longer acting the way that a femur acts inherently in the body, and yet that's okay. So it clearly doesn't make any sense, and they've obviously got this some subliminal rationale for going after these products, preventing them from competing with big pharma. Right? We know that there's a million different things out there that actually function via signaling or via scaffolding, donating something to the body. We know that's how they work, and there's irrefutable data that that's how they work. But if the FDA was simply okay with us just not saying it, then we could, in theory, have these 361 compliance letters that would allow us to openly market them. However, we don't. So it's just an interesting kind of thought experiment, right?
So I'm thinking through a couple of the topics we've brought up, and it's like, okay, again, how does a practitioner, and we've got a couple of orthopedic specialists on here. I would like you guys, Dr. Mata, Dr. Burman, like say something. I know you guys are like looking at using these or using these in your offices. You have this background in pain and joints, but it's this fascinating concept about what product to use, making it affordable for the patient and talking to the patient about it, but then knowing how to get the good result and not skimming, right? Because you can go cheaper, but is that really the right thing for the patient? And is it more about, I mean, how do you give an overview of what are you looking for in the right product? It kind of goes back to the beginning, but different. Like, there's the conversation around how many times it's been not manipulated, but processed, right?
Mhm.
How many millions or billions of cells or, communication
Exosomes.
packets are in a product, right? And then that might be the more expensive. So then you have this challenge of how do we get patients in? And it reminds me of one last thing. Jason's on, he might, if you don't know this, Doug, I have like had this total brain fart of, but I first heard it in Michigan last year with this big regenerative group using a football player. Who's the NFL football player that's the spokesperson for this regenerative medicine group? And they just say non-surgical, no longer need for surgeries or pain meds or whatever. You guys know what I'm talking about?
In Michigan?
Well, I first heard in Michigan, but I just heard it here at home a couple days ago. And so I don't know if it's national.
There's a ton of them, depending on what venue you're looking at.
Deion Sanders, I don't think it's Deion Sanders. It's Gull. You don't know what it is, Jason, who it is? Anyway,
I mean,
they're
I've seen,
talking very, yeah, Emmett Smith, there you go. They're talking very publicly about non-surgical, non-steroidal approaches to pain. It's no longer necessary. But then once they get in and you have to say, well, the best product for you based on, you know, how many millions or billions of cells and where we get them, is
right.
thousands of dollars.
Well, and this is a huge topic of conversation with all of the international medical tourism.
Yes.
Because those folks outside of the United States, you can advertise in the United States legally, as long as you aren't, it's not your clinic, you're not making these claims about what the products can do, what they can treat, and then you doing it under the umbrella of the FDA, which would be within the United States. So if you see on Instagram, as an example, Chipsa in Tijuana, DVC in Grand Cayman Islands, BioAccelerator in Medellin, Colombia, you know, et cetera. There's a bunch of them in Panama. I can't even count how many in Panama.
It's
Um,
you because Steve said Emmett not, then I was able to Google it. It's QC Kinetics.
they don't do allogeneic, FYI. I've had years of conversations with QC Kinetics.
That's the whole point. But I
Yeah,
also think,
yeah.
hey, they're getting away with a sense of marketing that's at least
Uh-huh.
creating awareness to people that there are non-surgical, non-steroidal approaches to pain.
Yep.
And that's helpful, I think, because it's less
So remember,
right.
again, let's go back to the beginning. Symptomatic advertising.
Yeah.
They're doing a great job of it. Now, look up QC Kinetics history. They got their wrist slapped really bad for not
Mhm.
exactly doing that in the past. So it sounds like they've learned their lesson. But they've also got, I don't know, 175 locations. I mean, they're massive now. So they have to be much more careful today in terms of you know, what could happen if their name got smeared with another FDA warning letter. I don't know. Like, honestly, back in the day, I think a lot of people used to be more concerned about that because practitioners and the public alike said, "Oh goodness, the FDA gave them a warning letter. They must be bad." And now people are starting to realize, I don't know if this is an advent of COVID and the way that this whole Pfizer thing was botched. I don't know what it is, but there's something about the kind of a general, I don't want to say distrust, but at least open questioning towards the FDA, understanding that they clearly have, just like you said, MedMasters has their people. Doug and his company have their products, right? The FDA's got their funding and we all know where it comes from. So you have to at least question the rationale behind decisions today. And I think people are more open to doing that. So when they see these warning letters, yeah, there's still like the newer entrants, I'll say, like, think of that bell curve of adoption. The new entrants, the people that are just learning about this, see a warning letter and they're like, "Ooh, yikes, FDA warning letter, I'm out. Don't want to know anything more about it. This is not for me." But the people that are at least on the upsurge, if not all the way here, and have already been involved in this industry, are like, huh, now that I think about it, I've seen a lot of FDA warning letters, and the only companies that get them are actually playing in the space that I'm interested in. Almost none of them have gone away, right? Like, there's a lot of people that have gotten these letters now and are still playing. I am, by the way, for sake of this recording, I'm not advocating that everyone go out and get an FDA warning letter. That's not what I'm saying. But what I am saying is try to find a different way of evaluating a product, because the FDA's warning letter, if you read them, almost exclusively start with illegal marketing almost every time. Then they go into what happens at the facility. And yes, there are some facilities that have just horrible QC. I cannot stress that enough. There are some that should not be in the industry at all, and that should be shut down. The FDA can't do that. That's outside of their jurisdiction. But with that said, there are a handful of others that I've actually seen myself and that I've reviewed all these warning letters from. Again, it's just not as cut and dry as they would like you to believe.
Yeah, I love what you said, though. Just find a different way to assess
Yep.
versus just, you know, what the FDA is saying or not saying. Because if the number one thing they're talking about is illegal advertising, that seems pretty simple to fix. It
Right.
seems something to work around, right? And I know that that then becomes the end question is, okay, so how do we market this? But have we explored some of the general premise of the basics of what type there are? By the way, did we distinguish exosomes from stem cells?
No, let's do that real quick. Especially since we're talking about different products on the market, when to select one versus the other. So in a nutshell, exosomes should be viewed as the mechanism of action of a stem cell slash a stem cell product. So exosomes come out of nearly every cell in the body. They are lipid encapsulated membranes, mainly consisting of mRNA and MI, so messenger and microRNA. So you're going to have, that's where your growth factor profile comes from. The information inside of that exosome is essentially uploaded from the parent cell, which is why the understanding of where your source came from, cellular source, of course, tissue versus blood, etc., that's going to tell you a lot about what the content of that exosome is. Ideally, one of the documents that you'd like to ask for is called a growth factor assay, proteomics, if you've heard of that. So those are really good ways to determine what the quality is. The quantity is a nanocyte, NTA, nanocyte tracking analysis, and it's becoming less interesting comparably to what it was forever ago. I think there's still a lot of companies out there. Again, I will leave names out of this, but companies that are basically, I'm calling it the numbers arms race, where they're like, oh, you have 5 billion, I have, 50 billion. And then someone's like, I have 1 trillion. It's like, what? Where did that come from? What are we even counting anymore?
It's so true. That's where it's like,
It's
we're the
ridiculous.
best, we're the best, we're the
You're right.
best. Because
Yep.
we've got billions and maybe trillions.
We have a microscope that nobody else has. I'm not going to company name, but yeah, right. Inside joke for those who know. So, like, again, the NTA matters if you've already established what you're counting. If you don't know what you're counting, I really don't care what your number is. We've seen this in amniotic fluid in the past. There is, ridiculous numbers of particles in there, and the skew of them will be all over the map in terms of size. So there's a lot of ways to understand data. And if you're just getting sold by a rep that comes in, with a strategic marketing piece that's got a real pretty pie chart on it or whatever, right? It's easy to skew someone's thought process if they don't understand the right questions to ask. So fun little teaser here. That's part of what we should talk about on that June webinar, is go really deep into each of those documents and explain to people what it is they should be asking everyone for, and just kind of set the record straight. That's the, I think, without putting words in MedMasters' mouth, but I think that's really the backbone of a group like yours, is let's give everybody the information and artillery that they need to be super dangerous out there, and no longer be kind of steered in one particular direction just because, oh, well, they've got a better trifold that's going to support my clients when they walk in the door. It's half the time it's a bunch of fluff that means nothing, and they're explaining what the word lilium means, right? Who cares? I don't
That's
care where it came
exactly
from.
right. Like, just arm you with what are those questions? What are those documents you should ask for? Like, what are we looking for in order to determine? Maybe you and I in certain sects like yours in this area, like me in ozone, like I know exactly where I would go for equipment, what I would do with it. Like I live and breathe it. So I've made my choices and I have my biases, but all I want to teach is how you guys can know how to do that and assess and move forward with what makes sense for you. And that's where Doug's at, is like, just what do you need to look for or ask for any of these sales guys or companies or vendors at the conferences, right? Whatever it ends up being, what do I need to ask and look for to maybe vet out and justify this is or is not a good product? And then
Yep.
it might be from different sources, right? So then you can go from
And it
there and
could be a
say, what do I want?
combination as well. I'm looking
Yeah.
at Dr. Matta's response here. He said, as a regenerative orthopedist, I use allogeneic products every day. When sourced from a reputable lab, these products are safe and effective, much better outcomes. So let's just, for example, I have a handful of orthopedic specialists that wanted to use exosomes. And that's great. It's a different source. So they're interested. They hear all the clamor out there. When you have an actual isolated exosome product, they are, among other things, safe for IV use because you've removed everything else. So that inherently tells you there's no scaffolding. You're going to have a really hard time localizing that product. So it's not, again, I am not saying don't use it for orthopedic uses. What I'm saying is consider, let's just say as a thought, if you're an adipose guy or gal, why not supercharge your adipose? Continue to use adipose. It's a phenomenal scaffold. It's the ECM components in there are of the best. Now you can make the signaling components even better. That's where the exosomes come in. There is no inherent lattice that the exosomes are going to provide. You would ideally like to have a landing zone for all of the endogenous cell population that's being signaled by your injection. So that's the whole idea with these products is we want to elicit a response from the body, kind of finally getting back to your original question, which is why would I pick one product over the other, right? Because there are certain situations where either the signal itself is unique or the signaling is more powerful. And in those instances, either maybe you have an older body that you're trying to influence, you're competing against other comorbid factors, you've got multiple injury sites. I mean, you can imagine that one of the examples we use all the time is rheumatoid arthritis. Oftentimes people are trying to treat that in isolation because, yeah, everything hurts, but certain things hurt more than others. And so, you know, someone who doesn't necessarily have a rheumatologist explaining what the actual problem is, maybe the patient wasn't even properly diagnosed. They're going to an orthopedic specialist who's treating an isolated area, and it's still, that stuff is going to get into the bloodstream and compete. It's going to be picked up by these other circulating chemotactic signals, you know, especially if someone's not on a TNF blocker of some sort. You question?
No, that's my personal experience. It's
Oh, there you go.
I think you like are telepathic also, because this is exactly where like my next question was going to be like, so, you know, stereotypically these are joint tools. These are, you know, orthopedic tools, but they have transcended, like you mentioned, into topical and aesthetic. But I, of course, am always fascinated with the IV. But I got from a company, this was years ago that I won't mention, got some stem cell product put in my L4-L5-S1. I broke S1 years ago. I was in tons of pain, and I was like, I got to do something or else I'm going to need like a hip replacement by the time I'm 50. And I did a whole series of things with PRP, with ozone, with these products, so on and so forth. Some IVs, like, of course, you guys know me. This is like my whole approach to life in general. But the back stuff, the hip stuff, referred pain was up and down for 3 or 4 months. And I think that's pretty normal. In the meantime, though, some of you have heard me say this, my vision went perfect for a year. I had to go to the doctor because I was like, why can't I see the TV? And we do the test, and I no longer need glasses or contacts. The other thing, like I just got localized. So you just said it's gonna bleed in, it's gonna become systemic. But if you want to have a systemic approach, think about what you're missing there too. You're not then able to scaffold or isolate. But my vision goes perfect. My hair grows like 6 inches in 2 or 3 months, and it's completely random, right? Like, you know, there would be no way for a provider to say, this is what's going to happen when I put some stem cells in your back. We're just hoping to help your back. But again, this concept of localized can bleed in. It's just like ozone or, you know, I don't know, IM injections of NAD or something, but it is very different when you do it systemically. So that was where I was headed, though, is some of these products now can be delivered. There's even PRP products that can be delivered intravenously. And I love what you're saying too, is like, how about we do both? Just strengthen one with the other. I know that then we got to get into cost and, you know, all that stuff for the patients, but.
Right. I mean, that's always a consideration. I think that's one of our topics when we do, it's called like a new office implementation, is explaining the menu of offerings and the rationale behind not just doing it one way. Because a lot of that has to do with pocketbook.
You offer this service?
Yeah, I mean,
kind of a consult service to help any provider look at their menu and say, when and how do I do these?
I mean, it's rare that I have that kind of free time these days. It is.
I was like, I'm pretty sure I could book your schedule right now if this is what you're offering.
I mean, honestly, that is how I structured my business for many, many years. And it's what I enjoy doing the most. So it's what, as soon as we can streamline a lot of our delivery systems for peptides and cells, that is what I want to get back to doing. And honestly, that's one of the many reasons I've been so excited to partner with you. By utilizing this platform, we can get some of these things out in mass form. And then I can fine tune it on an individual basis. But having to start from square one with hundreds of new accounts, as you can imagine, it's just not feasible. So being able to do, a MedMasters series and kind of break it down and then have each of those individuals call, email, text and say, hey, in this particular scenario or in this patient instance, what have you seen, right? Almost everything that I'm giving you guys today is not because I went to school any longer than anyone else. It's because I've been fortunate enough to work with so many wonderful physicians across, I mean, now internationally as well. I mean, I'll say I don't mean this as a plug at all, but kind of growing up in this industry under Dr. Herskovitz at ACAM, he's been a longtime friend. I've learned so much from him, and I've met so many other wonderful practitioners through that network. By no means is it the only network that we use, but those types of groups have that same type of focus where information sharing is continually promoted, and nobody's concerned about geographies, and stepping on someone's toes and taking one another's patients. It's just been a really healthy environment to learn a lot of this.
Yeah, I'm so motivated to help it grow and do it justice, and again be able to help providers really come full circle with it and just give you enough material to make it implementable. Because we talk about this all the time. You can go learn a bunch of stuff, but then it's overwhelm, paralysis by analysis of like, okay, I've learned so much, or I've talked to too many people, I don't know where to start. So that's why a service like, okay, let's look at, I do the same thing, right? I do it in the IV space. Let's look of in fact, some of these guys are my clients, have been, let's look at your menu of services. What do you understand? What do you enjoy? What do you like? What are the types of patients you treat? Let's figure out how to make all of that super rewardable in terms of finances and outcomes and all sorts of stuff. So it just is, in some ways we need to put it all out there, but then also compartmentalize it and break it down into sizable chunks that we can do something with, we can implement and really help people. So full side note though, I talk about it with MedMasters, but in terms of, I'll bring it back up later, is what I'm saying. In terms of, so there's IV, and I am correct, right? There is now a PRP product that is IV. There's exosome, and I was gonna ask you too, how would you fit V cells? This concept of V cells and all this. I thought that kind of died, and then I start hearing about it again.
Uh, yeah. All right. So PRP first. Obviously, we get it from your veins, and then we make it less viscous inherently by processing it. So there's no reason you can't use PRP intravenously. The studies are few and far between. I don't think there's any reason not to do it. It's very inexpensive. But in what scenario do you want your own stuff back intravenously? Right? Like typically when we're doing IV treatments, we're treating some sort of chronic disease state. It could in theory be damage, it could be brain damage, right? And I don't know. I can say with 100% certainty, I've never seen a study using IV PRP for some sort of brain condition. I'm not saying it can't be done. I just haven't seen it, so I can't speak to that. I just don't think that you would have a really hard time convincing me that that's your best option. Now, from a price point standpoint, sure, by all means, and that could inherently increase the frequency with which you get it done. I think there's a lot to be said for that. Increased frequency over just large, let's just say, cellular bolus. Kind of again the way that the international medical tourism community promotes these things. Hey, fly here once a year, spend 5 days with us. We'll put you up in a 5-star hotel, bring all your friends and family. You'll have a great time. They'll get hammered drunk and you'll get IVs for 3 or 4 days in a row. And then you're on your way and thanks for 30 grand, right? Like you can do it that way, but like what's the point of diminishing returns in regards to how much signaling is even available within that small time frame? If you ask me, I'd rather take, let's just say 100, 200, 300 million MSCs, whatever they're advertising, and stretch it out over the course of 6, 12 months, whatever it might be. I just think that the increased frequency of application and smaller routine application, it's rare that your body actually needs that much at once or can use it. The great part about it is it's super safe. The worst case scenario is you're not going to utilize it. Like, there is no side effect. There could be some side benefits, as you mentioned, your eyesight, your hair growth, right? Like that could certainly happen. But is that really your anticipated clinical endpoint? And is that really why you paid however much money you paid to go to Grand Cayman Islands? Just saying.
Got
V
it.
cells. I remember when that information first came out, and I was marginally excited. I mean, I still got the feeling even out of the gate, and I was like, well, this sounds way too good to be true. Very small embryonic like, so that's the V cell.
Yeah,
You
I was
know,
gonna say it like the
yeah,
way, and I worked for Avi too, and we did like
yeah.
just like ways of understanding it. He used to do presentation. He's the one that did my injections. But it was like you got stem cells, you got exosomes, and you got V cells.
Right.
And so their accessibility, their maneuverability, their rheology, et cetera, was so fascinating. But
Yeah, I mean, the theories are very fascinating. A lot of the people that initially introduced that to me are no longer interested in it. So I think that, and again, this is where I get a lot of my information from people much smarter than me. And those same people are now kind of moot on the subject. There seemed to be a lot of marketing behind it. It sounded super cool. Like, yeah, trust me, you can't see these things. You know what I mean? Like,
yeah.
until there's some more serious data on it, I just don't see how you structure a clinic around it. There's a lot of information that I still need to see on that before I'm completely sold on the idea. Again, I don't think it's harmful. But we're talking about, oftentimes in this industry, the worst thing is that predator that goes out and improperly, caters to the elderly or whatever it might be. We hear about it all the time in certain verticals more than others, but that could be the ultimate detriment to our industry. So we definitely want to make sure that whatever it is that we're promoting at least has some solid study-based validity behind it. And I just personally haven't seen it yet for V-Cell. I'm very familiar with the information and the theories behind it, but I haven't seen anything concrete yet.
And I think one of the other opportunities that you and I have is to hear from providers, like those that did say, hey, this is interesting, let me see and try, and did they get good results? And I think you're also saying you haven't seen enough in that category to convince you
Right.
otherwise either. I'm the
And
same.
even the people I trust haven't seen enough.
Yeah. There's this, I'm sure since you're familiar with it, there's this whole sidebar or advancement technique of using ultraviolet light, using
Mhm.
light
Yeah.
to guide these V cells. And so where we were so involved in the ultraviolet space or the light space, this was like, is there something here? And I knew people that went and did it, tested it. I've got, again, really trusted people who, are promoting it, big names in our industry. I won't say them. And then you have to wonder even what role placebo plays in that, right? Like they believed there was something great there. They, in theory, liked the way that it presented itself. And, so it doesn't mean that people didn't think it was great or get some results, but I just was curious as to if you felt like there was any good studies are hard to come by in some cases, but feedback, clinical data that said, yeah,
Right.
that's definitely a product to look into.
Well, and as you know, light therapy has a tremendous amount of data behind it. We
Yes.
know with a high degree of certainty what those different wavelengths do, the depth of penetration, whether or not they're antimicrobial, whether or not they guide cells. We know a lot of those things. So I think, again, the intention there was pure. And I'm not saying that those things don't they wouldn't properly affect V cells. Perhaps they do. I just haven't seen that definitively. But for example, we use those same strategies with stem cells and exosomes. So we know that they have that propensity. There's all sorts of different ways to even using like I want to say it's like, I should know this better, 670-ish nanometers, something like that from a red light around a joint space, helps to localize that treatment a little bit better. Now, is it going to help even without exosomes and stem cells? Probably. Will you notice it? Maybe, maybe not. Depends on your condition, right? Like we know that these things we know what their mechanism of action is. So in theory, all of these synergies together should have some version of effect. We just don't know if the effect is going to be greater than any one of those individual modalities on its own.
Yeah, I think at least what I was hearing, or one of those theories for V cells, was just the nature of how small it was. You know, we're always looking for things for blood-brain barrier,
Mhm.
you know, things that will get through that, and like you mentioned, brain health. And so with the size being small, and maybe we could guide and direct this stuff to go where we want it to go, is this something potentially that can get through the blood-brain barrier? And you know, like it'd be so cool if it appeared, if it happened. I working in different offices, I saw a couple things very, very cool and suggestive and exciting, but I will say that it retracted. You
Yeah.
know, we saw some progress, but it didn't hold, and doing more of the V cells did not create more advancement. In fact, it stalled and reverted. Exciting, you know, there's got to be something there, but it wasn't something that, you know, we felt we could comfortably, you know, sell. So,
Let me give you another example. So in terms of you go back however many decades to where we first started to generally believe in science that there are certain types of cells that are going to have a better propensity to be applied in certain types of instances. I think in general, that's kind of what you're talking about with brain, right? We want something that's small enough to cross the blood-brain barrier, but then also specific enough to hopefully do something relevant, whether it's reduce inflammation or regenerate tissue, improve, regenerate nerve endings, remyelinization, whatever it might be. We've talked for a while now about hypoxic cells. So reducing the oxygen content in the culture itself. So essentially prepping the cell and then subsequently also the exosome that comes out of that cell for a low oxygen environment like the spine or the brain. So this is something it's already being done. This is not news whatsoever. But that to me is a much more immediate and well-studied alternative because I think ultimately that's what so many people in the commercial side are looking for. They're saying, okay, what's the next thing that I can market? Okay, so PRP's been out. What if we make PRF? Like, dude, the dentist did that 20 years ago. And like give credit where it's due. You didn't come up with that. There's nothing novel about PRF. It's just people are so ignorant to the history of our industry. So I think a lot of times that's what we're looking at. There are products that are being put out there and promoted in ways that, it's been 5 to 10 years, like, hey, these dummies will forget that we already did this. Let's say it again. Let's see what happens. I think that's one of my biggest interests, honestly, is hypoxic. Because if it has the capacity to survive longer in low oxygen environments, I liken it, and this is just my dumb athletic background talking here, but I liken it to an athlete training at altitude. Wouldn't it also make sense that that same cell is now even more effective systemically? Right? You've got, what is it, 21% oxygen, I believe, is kind of the general standard for around the body. Then you've got 1 in the spine. And we think that the stuff we take that's old, comorbid, and processed, and then combined with some sort of anticoagulant, spun in a machine, that we can put it back in the spine, and it's going to have any level of survivability. I'm not saying it doesn't do something, but to think that the cells themselves have some amount of longevity to them without prepping them for that environment it's kind of ignorant.
so I think we should save the majority of this conversation for the course on the 7th and 8th, but this is always a question. You mentioned synergy and you mentioned prepping the body.
Yep.
In a real quick, totally biased, opinionated approach, what are your top 5 synergistic therapies with stem cells, and top 5 things you see providers doing to prep the body to get the optimization out of these products?
Well, I'm a huge fan of ozone. So there's,
I didn't pay for that. I did not pay
right.
for
depending on your scenario, EBU versus high dose, kind of like we don't have to go too deep. And I'm sure a lot of people understand on this webinar why you'd pick one versus the other, depending on your situation as a patient. Similarly, you can talk about hyperbaric, right? Those types of things make a ton of sense. I think a good IV vitamin regimen, again, depending on your situation, but you could even throw in things like NAD, BDNF, if you want to get into the brain, alpha GPC, right? Like crappy answer is it really does depend on what exactly you're prepping for, what's your clinical endpoint, but peptide therapies in general, vitamin therapies in general, oxygenation, and what else can we call ozone? Free radical destruction, something like that, right? Like I think basically anything that you can do to proverbially plow the road and remove as much of the low-lying inflammation and competing hemotactic signals to allow, let's just be honest, the more expensive treatment, which is the stem/exosome, to be more specific to your anticipated clinical endpoint. And I keep going back to that word anticipated, because when someone comes into your clinic, they're going to tell you, this is why I'm here, and this is why I'm willing to give you X amount of dollars to hopefully fix this problem. That's their anticipation. These products don't necessarily always listen to you just because you meditate on them. It doesn't really work that way. So we have to be as specific as we can, applying these other types of modalities to hopefully at least get rid of the other things that are going to try and rope them in and distract them. Because again, they can have side benefit like vision and hair growth, right? They can do that, but it's not what you're paying for. So yeah,
I don't know. I'd give anything to go. That vision thing lasted a year, and now I'm back to what it was. So I'd kind of
right.
like love to. I've done exosomes several times since, and I'm like hoping for this. My back is like 100%. So now I'm like, where else can I go?
Right.
Not to be suggestive, but I love what you said. Is there equipment? You mentioned laser. I know PMF. Are there any of those things you'd throw in there?
Yeah, I mean, again, I would say, again, depending on the scenario, some version of red light therapy, I've seen be pretty effective. I've seen, gosh, these 4 beds, they're extremely expensive now, but people seem to be getting really good results from them. Yeah, for orthopedic indications, there are certainly scenarios where shockwave, even like grass thinning, dry needling, there's so many techniques that can help prep an area. I think especially things like shockwave, if we're talking about applying to an area that either needs initial re-stimulation or a long time collagen buildup, so a scar that you're looking to get rid of or work through. And I don't literally mean a physical visible scar on the surface of the skin. I mean, like yours truly, I probably have a tremendous amount of scar tissue built up on my hamstring because I have torn it multiple times in the past. And that repetition of tear kind of changes the composition of the muscle fiber. So if you can get in there and kind of break it down over again, it's really not that much different to the rationale behind microneedling or lasers, a full burn down, as the aesthetics folks call it. You're taking a
Something
step
to
back,
like
take 2 steps forward.
not hydro, it's not that we're talking about water, but that the dissection of even the fascial layers and we know there's so much communication. Am I sticking? We know there's so much like communication there. And scar tissue this is Eastern medicine, but scar tissue does hold and behave different. So are there ways to break that up? And you just made me think the only thing I'd add on top of what you had is neural therapy as kind of a point of getting nerve communication, pain patterns reset, and maybe even using a combo of procaine and ozone to change the scarring in any area.
100%. I have no doubt that I'm missing a handful here that I'm
No,
sure there are people who watch this that are like, oh, Doug didn't say it. You're all right. I'm sure there's a bunch of other great modalities out there.
But that's the point, is just that while this is kind of my own philosophy and I don't want to get on a tangent, but your job is to present what you think would provide the best outcome. You're really doing the patient a disservice to say, because it's $5,000 and I'm worried you can't afford it, Mr. Smith, we're only going to offer you stem cells.
Right.
When, if you're honest with the patient, you're like, but for that $5,000, if you added these other therapies in, even if it doubled the price, there would be a much greater chance that we got a quicker or more comprehensive outcome. To me, that is the ethical thing to do, and
Yeah.
let the patient choose where they would like to stand in terms of the value of their own health or condition or physical status.
I think as a business owner and a practitioner, as you do these types of procedures more and more, you'll get to the point, even regardless of the financial upside, you will get to the point where you will turn down business from people like that. And it is the right thing to do. You know, I think eventually I've seen it with so many accounts that we've worked with over the years, that if they have a patient that they're consulting that comes in with all the wrong ideas about it, more often than not, that's the patient that winds up giving you a bad review anyway, because it doesn't work, right?
Yeah.
Like they haven't come in with an open enough mindset to realize that this is not a silver bullet. That just doesn't exist. I'm trying to remember the name of this gentleman. And I'm embarrassed that I can't. He was, or is, I should say, he's still alive, an understudy of Dr. Arnold Kaplan, you know, the father of the MSC, the guy who coined the term. Forgive me if he ever watches this, I'm sure he won't, but I was on a
We're not
webinar
that
with
big,
him.
Doug. Not that big yet.
And in all fairness, you know, there wasn't a whole lot that he said that I haven't already learned. You know, he was kind of reviewing, this is, Dr. Kaplan is a pioneer, but of things that all of us have already studied. Like you don't play in this industry without knowing his scripture. And so I didn't really learn much, but one thing he did remind everybody of, which I think is really important, is when you have a chronic scenario, for whatever reason, whether it's disease or injury, the term chronic typically means that the body has essentially given up on it. So it's not really responding to the chemotactic signal anymore, and or it's maybe not even giving one off anymore. And so all of your question about what other modalities could use to prep the body, I think this actually goes back to starting in consult and understanding, what are we actually dealing with? Did I really diagnose this properly? And if so, what do I need to do to reasonably re-aggravate this thing, whatever it is, enough so that a cellular or acellular product, exosome, stem cells, etc., actually has a chance to respond to the signal? Because otherwise, if we're treating it in its chronic state where it's not asking for help anymore, this stuff's going to go elsewhere anyway. So you almost have to do it. I remember just another story back from J&J when we were promoting microfracture surgery. And a long time ago, Kevin White got drafted out of WVU as a wide receiver. I'm a Green Bay Packers fan. He went to the Bears. I was terrified. He wound up having microfracture surgery and never did anything. I don't wish any ill will on Kevin, but I remember that happening. And I was like, man, that surgery probably sucks. I feel bad for promoting it, right? Like it can have a very detrimental way of manifesting, but the idea of microfracture is to punch holes in the top of your, I think in this instance, it was his knee. So I believe it was the tibial plateau. So I think they were actually almost like aerating the top of that bone to allow marrow to seep through the top, get to the cortical level, and then hopefully resurface. I mean, you can imagine how invasive that is, but the idea is we're creating an injury to heal even better. And that's in a way what I'm suggesting here. I'm not suggesting microfracture, obviously. But that same
Sometimes the re-stimulation of the body's own mechanisms, right? They're stuck or
right.
they're not responding. Or we always used to say there's collateral damage, right? A chronic situation means that the immune system or the healing factor has been in this situation, the area trying to do its job, but doesn't have the resources and now is simultaneously doing damage. That's not an autoimmune disease. So you have to address that. Not sometimes, a lot of times, not just, put a bunch of, in some ways, I think these could still be coined as band-aids, like we do conventional medicine. If you don't maybe get to the root cause or remove the barriers, plow the way, like you said, then we might be overselling the potential of any of these products.
Yep.
All right, Doug, we are like 20 minutes past. I always like to keep it an hour, but we always have interesting conversation. We've got everybody. Let's answer some questions and then push everybody. I'm being so transparent. Like, we definitely want you to come. To our next webinar is May 7th. I don't have a slide for this, but we're going to show you my slides. May 7th with Suzanne Fury. So, used to be Suzanne Turner, if you know her by that name. She's phenomenal, out of Atlanta. Again, just published a book on peptides, and you can just, to me, this is everything. When the doctor looks, feels, sounds, practices what they preach, it is somebody I want to listen to, and she's definitely one of those people. But we've got our all things peptides and human cellular tissue products on June 7th and 8th. So Vicky's going to post some of this stuff, but really quick, are there questions or comments? Dr. Mata, thank you so much. He has also given me injections. I would definitely go there over and over and over again. We've talked about him doing some presentation and teaching. He's so integrative. I helped set up his e-bill. We did definitely some business development together. He's fantastic. But I think he's also coming at this, hey, Doug, approve this for me really quick. So I use MSC, ACM and joints, tendons and spine. I use a more pure PS or MSC product around nerves and IVs. I reserve exosomes for more degenerative conditions and intrathecal injection. I also like to help cell-to-cell communication with peptides, BPC and copper. Thoughts?
I mean, I would have
I
a
don't know how
hard
you
time.
argue that. I mean,
Yeah, I'd have a hard time improving on that. I
yeah.
love the fact that he understands, of course, that the scaffolding in the joint space is, again, in my opinion, imperative, because it's really hard to localize this stuff otherwise. Not to mention, oftentimes the rationale for using it in joint is reduction of some sort of cushioning. Without getting into the homologous use conversation, right? These things should have a cushioning factor to them. So certainly important there. Definitely same thing for tendons and spine. I mean, tendons, avascular, these things are going to respond really, really well in avascular scenarios because you've got a lot of vascularity properties to them. And then spine, I mean, it's hard to have a part of the body with more natural chemotactic signaling than the spine. And certainly agree, purified MSCs when you have the option, especially for IV, but definitely around nerves in the spine, around the spine. The only time I'm not terribly concerned is if you're going paraspinal. And I have people that will argue that when you go into facets are joints, you can have osteoarthritis in there. They like the idea of putting something viscous. I just don't see the benefit in comparison to the risk personally. So I tend to agree with Dr. Mata here. And then, yeah, I like the idea of improved cell-to-cell communication. I mean, BPC is kind of your Swiss Army knife. There's a ton of angiogenic property to it, right? There's a lot of analgesic property to it. Pairs really well with copper. Could also pair really well. The only thing else I'd add to that is thymosin beta 4. TB-FRAG4 has almost like a tissue regenerative specific profile to it. So that might be another thing to consider just in case you want an even sharper sword there. But yeah, I love that, Doc. I saw, Kim, if you want to review Regina's comments, I saw her earlier.
Yeah,
And
yeah, she's got some technical legal reasons.
So her second question is going to help answer the first question.
Got
it. So I'll read the question for those of us that aren't watching. She said, you guys were talking about endotoxin issues and sourcing materials for compounding in our previous webinar. Are the FDA registered products going to be required to submit testing? And I'm going to just show people her previous question. So previous question was, do birth tissue products need to be FDA registered, not just the company itself, for use in patients? So let's start again with the second one. So the endotoxin issue is a super important issue, especially when we're talking about anyone that's dealing with an already inflammatory state, which oftentimes we are. So sadly, the answer is no. The FDA registration has exactly zero to do with the product, which you really shouldn't be too surprised about. It's the FDA we're talking about. The purpose of an FDA registration for a company and subsequently for the products that they make is essentially saying, hi, my name is Company X. I make HCTPs that I intend to be 361 compliant. But by putting them on this, I think it's EHCTERS database, I also understand that they have not been reviewed by the FDA, that at some point you're going to come to my facility and audit me. And if and when you do, and you give me a 361 compliance letter for my flowable product, I will be the first one in the country to have one because nobody's got it. So it hasn't happened yet, which means every single time that the FDA has visited a facility that has properly registered, no one's gotten any sort of approvals of any kind. So keep that in mind. So back to the original question. Do birth tissue products need to be FDA registered for use in patients? So the for use in patients part, let's just ignore that for a second because the utilization of really any of these things is not regulated by the FDA. So the for use in patients thing, I think there's a really important aspect to consider. And I would actually love to hear, is it Jeff Cohen, your attorney? I'd love to hear Mr. Cohen's input on this. But the registration aspect is important if you anticipate that you are a compliant HCTP. This was the purpose of 21 CFR 1271.10, which a long time ago in the 90s had been, kind of repurposed over the years. November of 17 is when most people became familiar with it because that was when the FDA said, all right, everybody in this industry, you've got 3 years, and we're going to give you the next 3 years to figure out whether or not your products are or are not compliant 361s. If they are not, and you want to maintain some level of marketability for them, you need to submit for clinical trials, biologics license application, investigational new drug approval trial. So those two things, BLA, IND, you've probably heard these over and over again. That was the whole purpose of that document. We got an additional 6-month extension during COVID. So in approximately May of 21, Dr. Peter Marks, who heads up CBER, came out and said, hey, everybody, party's over. You now have to essentially understand that we're going to start the enforcement period. And Kim, this is kind of what we were talking about on the last webinar. None of this stuff is new. The scripture has all been there, but there has been what they call a discretionary period for a while. And there is now subsequently the enforcement period where there was some discretion as to whether or not you properly interpreted this or had enough time as a company to go through the processes to get a BLA and an IND, et cetera, et cetera. This is really not that much different. So crappy answer to your question, Regina, is I don't believe that you need to be registered in order for these products to be used. Now, that is much different from a manufacturing side and from a any instance where you want to market, label, make claims, advertise in any way, shape, or form. So you can still, as a medical license holder, you can access all sorts of things that don't have any sort of FDA approval, aren't properly registered. It doesn't mean that you can't use them. It does mean that, just as you would probably expect, it's going to be much harder for you to get some sort of malpractice coverage for it. And you will likely be standing on your own with your attorney should anything happen. But that's not all that much different from a lot of these other FDA approved items that people use off label. Right. There's a lot of crossover there, and there probably is something that I'm not familiar with that talks about it, not just birth tissue, but just products in general needing to be FDA registered for certain things. But I have yet to see any scripture that says anything about FDA registration being a prerequisite for a physician's use of these products. It really does become, I'm missing the term here, but up to the physician, their practice of medicine once they receive these products. There's certainly going to be a little bit more to that, but in general, these products, I do not think that there's any scenario where that's an absolute requirement, mainly because the whole point of the registration is to have the intention of being 361 compliant, and there's not a single one that is. If they were, they would have a regulatory opinion letter stating so, the way that these other birth tissue allografts do on the wound care side or on the surgical side. right? There are products that have these letters. So if someone in our space felt that they had some road that would lead them to some version of 361 compliance, they would have done it, because that would give not only them, but all of their clients a whole unique ability for marketing.
So marketing is a big thing, but you mentioned malpractice. Do you have, and I'm working with Jeff Cohen on this. I mentioned him before, but we're sending referrals to him. He can guide you through your consents, through your, any legal situations where you get your products, all sorts of things. Again, he believes and practices integrative medicine, so I call him an integrative lawyer. But do you have, we get this, Jason and I, MedMasters, we get this question multiple times a day. Do you have any resources for malpractice? And if anybody here wants to share that, I know scope and state and everything's different, but any off the top of your head where it's like, hey, try these guys. I've worked a lot with it. I'll say this, and it's not necessarily hard to get. It just costs more money. But an attorney can, help guide you through what that looks like, and, how you practice, how you state your scope, how, all these things can play a factor. But we get asked all the time, and we've got companies we throw out there, but do you have anybody?
I do. I'm looking at it right now and I want to share my screen, but I need to delete this guy's name real fast. There we go.
Are you able to share? Do you have
I
access?
can. Yep. Give me 1 sec and I'll pull it up. Here we go.
Yeah, I took some notes on Baxter and Associates. Admiral, I've heard of, yes.
Yep. So this was an application that I actually assisted one of my accounts in completing, which is why I wanted to delete their name. But this is, let me see if, yeah, I'll leave it here. Actually, I don't mind sending this out to you if you'd like, but this is the most complete one that I've seen. It is a little bit tricky to fill out because there are a couple questions here, these in particular. So they'll ask a handful of these things over and over again in different ways. So just know that when you read it. And again, I'm happy to walk anybody through this that needs help. But for example, what type of laboratory stem cell processing equipment is used? Most of the time, you're not going to know the answers to these things. There's, are you involved in clinical trials? Of course not. Most of these companies that you're working with, even if they are involved in clinical trials, you can't leverage any of them anyway. So it's, keep that in mind. There will be a few things on there that you'll have a hard time answering. I can at least give you my suggestion as to what attorneys have told us to fill in there. But it seems to me like these folks are very open to providing malpractice insurance. And I think part of the reason is because they realize worst case scenario, there's side benefit, not side effect. It is a very safe thing. They're not insuring you against an FDA warning letter. Right. They do ask you a little bit about your marketing strategies. And of course, the answer should be, we don't market because it doesn't have FDA approval. Right. That's very common knowledge. But other than that, I think that it's actually very telling for our industry that insurance companies are seeing the reasonably low amount of risk in doing these procedures, and they're willing to give you insurance for it. That tells me a lot.
Yeah, that's cool. I think though there is a way to navigate it, like a lot of these technical forms are, there's right ways to answer it to get, to the result you want. It's very good to know that you have, are offering some assistance there if anybody needs it. Oh, Dr. Hinman, last question. Maybe you can,
I saw
decode.
that he was saying specifically in the facet, it can only take 0.2 cc. I think you're pretty close. I've talked to people doing 0.5, but I agree. I think more than that, you're probably going to be agitating it a little bit more than you want to. Those are really small areas. And this is actually, I think, a transcending question, because so many times we have dealt with physicians asking, all right, so how much do I use in terms of volume? How much do I put in the knee? How much do I put in the shoulder? The reason that they're asking this question is either because they've been taught from, let's hope at minimum, a PRP background. For the most part, PRP is going to be reasonably similar. So we're going to give you protocols based on volume, even though we all know that there's a high degree of variability in terms of quality of PRP. In theory, you could use 10 mLs of a really crappy low concentration PRP, and it would be less effective than 3 mLs of a really well procured, highly concentrated version, right?
How
So
it comes back to
similarly,
price and quality and, all these things play a role in what the outcome's gonna be.
exactly, right. And so that exact same understanding should be applied to all of these other products as well. Is that just because you're used to using a certain amount in terms of a volume, that amount does not necessarily equate to outcome, to signaling capability. You wouldn't think that if you're going intrathecal, actually, let's go even cerebral spinal fluid. Say you're going CSF for a brain condition, and you're a very aggressive spine trained anesthesiologist, of whom I know very few. These folks are treating some. I had the pleasure and also displeasure of presenting after Dr. Doug Spiel
Oh,
at ACAM, actually. And he was literally showing videos of him doing CSF injections for pediatric paralysis patients. And these kids were walking within 8 weeks. I get up there. For those of you that can't see, I am completely bald, and I'm giving a follow-up presentation on hair restoration therapy. So literally, Doug gets a standing ovation. Like you're saving the world, you're helping.
yeah.
And then Doug 2 comes up and I'm like, hey, who's ready to talk about hair? And they're like, first question, does this stuff work? Because you're bald. So yeah, awesome.
Oh my gosh, that's awesome.
Yeah.
That's
But I
terrible.
mean, talk about a pioneer. Spiel, man, I know he's not technically in our industry anymore, but I can speak for a lot of us when I say we miss that guy, because he really pushed the envelope. Whether he's on your team or not doesn't matter. That guy, his application strategies I learned a lot from him.
Yeah, yeah. Pioneer for sure, and definitely
Mhm.
above many in
Hell
terms of
yeah.
his understanding and teaching. Um, okay, Doug, I think
About that
we've
time.
done some damage here. I think we had some good interaction. I want to ask everybody to bear with me as I wrap this up and remind everybody of their options moving forward. We always want to take that next step into phase 2 or phase 10, wherever you're at. Number one, I made the disclaimer, but Doug and or I are available to continue this conversation privately if you need any sort of direction or consulting. You need a lab, you need a product, you need help understanding products. Doug especially is available for that. Doug, do you want us to just again add your contact form or your email address to get people in touch with you?
Perfect. Yep, that's
Okay.
great. Thank you so much.
So in the follow-up email, we'll add that in. It's real easy. If you have my number, you can text me and I'll loop you into a text. I've been doing that a lot with Doug. Doug's right in the middle of finishing up his full distribution website in terms of being able to purchase and get in contact and really make that automated. So we're super excited for him there, but we got to wait a few more minutes until that's totally ready. So we'll just hook you in very directly. But you won't be disappointed with the information that you can get with him. As I was saying in the disclaimer, he does work with the companies, with labs, teaching. We're going to come together a lot further on teaching these things. So that is where MedMasters comes in. And next steps might be this class for you. It's called Here All Things Peptides, but we will also roll into these other aspects. We're going to dive deeper into very specific peptides and applications of human cellular tissue products from the gut perspective, the neuro perspective. I do literally have you on my list, Dr. Mata, to be like, hey, do we want to get into joints and pain? The optimization, we've got the legal aspect, we've got we've even got Leonard, who is going to be talking about metabolic health, also alternatives to these things, where to source these, and again, like email and social media experts that have figured out how to leverage. Brett and I were talking about this so heavily the other day, Brett Sandala, on how to use education to successfully build your practice, right? You can say stem cells, you can talk about these things when all you are doing is educating, and then what to stay away from and certain things that you may or may not be able to post. So full 2-day event there. Again, if you, let's say, use the link, I don't think that this code is correct. Or you're a member. So let's go backwards just a second here. MedMasters is in business to teach you and educate and provide good medical knowledge, full scope business development. So we work on a membership basis. If you want to pay, or if what sounds good to you is $250 a month, you get access to one vault. So there could be an ozone vault, a peptide vault, a human cellular tissue vault. You know, all these things are being recorded. You get discounts off trainings. You get the live interaction and Q&A with us. You can get some hands-on training. You get access to these affiliates that we've got, and those provide a lot of time and money savings. I've been working with dozens of companies to be able to create these partnerships to bring you savings. So I'm really excited over the next year to be bringing that to you. If you do $485 a month, you get access to all our vaults. If you go to our website, you can actually see what those vaults are. I'm going to give you a heads up and say that some of these prices are probably going to go up soon because we're adding so many vaults. The value is going to go up. They never expire. You can cancel your membership at any time. You get SOPs, you get patient education, you get staff resources, everything again to come full circle with your practice. Then we've got our live virtual event. The next one is peptides. Well, besides this one, we have 2 seats left, by the way, 2 seats left. If you're interested in regenerative aesthetics, with Lexi, you and I, plus some other people there, lots of vendors. But I do have this question of like, how are you growing your practice in 2024? Are you adding services? Are you enhancing services? And in the IV space, you can definitely, if you've already got an IV room or an injection practice of any kind, you can definitely leverage that into aesthetics. So we'll be presenting for 2 days in Indiana. This one's live and there's only 2 seats left, but make sure you become a member because you get 10 to 20% off of the class if you do that. But two seats left. The last super fun offer, I'm very excited to be partnered with ACAM. It's their 50th anniversary celebration in May. It's another conference. You may already have your schedule full, but if you have any space for this, we have an exclusive offer for MedMasters clients. So you get 30% off the main conference when you register for the chelation. If you are not chelation certified yet, they are the grandfather, the founding fathers of chelation education. And so they've got a pre-conference training. If you need to go through chelation, you want to go through chelation certification, and it is truly certified, and you purchase it, there's a code, MedMasters30, that you put in on their website. It'll give you 30% off. And I'm going to add to that and say, if you purchase an ACAM ticket, then you'll get an additional $50 off our All Things Peptides class. So buy one ticket to ACAM, get a bigger discount to the peptides. So it's kind of a 2-for-1 thing there. All right. Any other resources we need to share with them, Doug?
I don't think so.
They've got your contact. You do have peptides and products available that they can learn more about if you're in the business or not in the business, but if you're looking for either understanding the products or getting the products. And then we'll have clarification on this coming. So
Perfect.
all right, you guys, thanks so much for your time on a Tuesday afternoon. We appreciate you. We appreciate your service to humanity with looking into all the regenerative and extra tools that you didn't learn in medical school for the betterment of society and your willingness to serve those people. We're so fortunate to be partners with you in that. And we look forward to seeing you May 7th with Suzanne, Dr. Suzanne Fury. You'll get those invitations and links to register. In the meantime, go forth. Master the art of healing. Take care, everybody.